Good morning, I am Dr. Henna. The topic of today's presentation is surgical management of vitiligo. To begin with, vitiligo is an acquired condition resulting from the progressive loss of melanocytes characterized by milky white, sharply demarcated macules or patches. Vitiligo can be classified as segmental as well as non-segmental. The recent Vitiligo Global Issue Consensus Conference classifies vitiligo, encompasses the term vitiligo encompasses non-segmental vitiligo including acrofacial, mucosal, generalized, universal, mixed and rare variants of vitiligo. Segmental vitiligo is classified separately. Undetermined or unclassified vitiligo include focal lesions which are small areas of depigmentation which are neither distributed segmentally nor have they evolved into non-segmental vitiligo in 1 to 2 years. It also includes isolated mucosal lesions on one side. The treatment of vitiligo includes medical as well as surgical management. Coming to the treatment proper, vitiligo surgeries. Historical aspects of vitiligo surgery. In 1964, Bale from India was the first to describe the surgical treatment of vitiligo in a large series of 107 patients with thin Thiersch grafts. Falabella in 1971 first described suction blister technique and in 1978 described miniature punch grafting technique. And in 1989, in vitro cultures of melanocyte bearing epidermis was described for vitiligo treatment. In 1992, Gauthier and Sorley-Basile first described the use of epidermal suspensions obtained by tryptonization. This technique was further improved by Olsen and Julin by adding a melanocyte culture medium for additional growth. Basic principles of vitiligo surgery. The basic principle is to achieve cosmetically acceptable repigmentation of vitiligo by transplantation of autologous melanocytes from the unaffected pigmented skin or hair follicle to the lesional skin, which will then function as an epidermal melanin unit. But it cannot stop the progression of the disease and it is indicated for resistant stable vitiligo that doesn't show adequate response to medical therapy. Factors affecting the choice of surgical treatment. It includes type of vitiligo. Vitiligo surgery can be used for all types of vitiligo provided the disease is stable. Extent of vitiligo. Segmental vitiligo has a good response to surgical treatment. And for extensive lesions, the choice of treatment is cellular grafting. However, non-segmental vitiligo involving a body surface area of more than 30% is preferably not taken for surgical management because they are likely to be immunologically unstable. Then site of the lesions. Acral lesions have a comparatively poorer response to vitiligo surgeries, so counseling should be done properly before attempting surgeries on acral lesions. Also, areas such as eyelids and lips should be carefully approached while doing the surgery because of the anatomic as well as cosmetic importance of these sites. Age of the patient. Younger patients respond better to vitiligo surgery. Patient's attitude and requirements should be considered. The patient has an unrealistic expectation out of the surgery, that is a contraindication. Then availability of facilities. The techniques like cellular grafting require sophisticated facilities as well as costly equipments which may limit its utilization. Then expertise of the surgeon. Cost of the surgery. Whichever surgical treatment chosen should be affordable to the patient. And stability and test for stability. Stability. The duration of stability varies among different authors. The IDVL Task Force for Standard Guidelines of Care for Dermatosurgical Procedures defines stability as a patient with no new lesions, no progression of existing lesions and absence of Kopner phenomenon during the past 1 year. Individual lesional stability as well as the overall disease stability is important in selecting patients for vitiligo surgeries. Cellular stability. Markers such as CD8 are useful in indicating the stability of a lesion. It has been observed that if there is a high percentage of cytotoxic CD8 T lymphocytes from the lesion, there is a high risk of failure of melanocyte transplantation. In spontaneous versus induced stability. Induced stability is a stability induced by medical management. So it takes into account period of stability of repigmentation. That is, the repigmentation acquired after treatment should be maintained for a period of not less than 1 year. test for stability. First test is test grafting or mini grafters introduced by Falabella in 1995. In this, 6 to 8 test punch grafts 1 to 1.2 mm is placed within a vitiligo lesions and dressing given. The dressing is removed after 2 weeks followed by sun exposure for 15 minutes daily or NB-UVB for a period of 3 months. The test sites are then visualized under wood slab to assess pigment spread. The patient is deemed fit for surgical intervention if there is an unequivocal pigment spread 1 mm beyond the margin of the implanted grafts. VIDA score. VIDA is Vitiligo Disease Activity Score. It evaluates the disease activity on a 6-point scale. A low VIDA score indicates less activity. And the patient is deemed fit for vitiligo surgery if the VIDA score is less than or equal to 0. So if the disease is active in the past 6 weeks or less, VIDA score is +4. 6 weeks to 3 months, it is +3. 3 to 6 months, it is +2. 6 to 12 months, it is +1. And if it is stable for at least 1 year or more, VIDA score is 0. And along with this, if there is spontaneous repigmentation, it is -1. So this 0 and -1, patients with this 0 and -1 score are deemed fit for vitiligo surgery. Contraindications of vitiligo surgeries. Unstable disease. If there is any active infection at the recipient or donor site, then active herpes simplex infection when operating on lips and perioral areas, bleeding disorders, keloidal or hypertrophic scar tendency, and unrealistic expectations. Those with significant fingertip involvement, periorificial or acrofacial distribution, and isolated scalp leukotrichia are poor candidates. Patient counseling. It should include detailed information about nature of the disease, type and rationale of surgical treatment chosen, expected outcome, need for proper immobilization after surgery, and possible complications. Patient should be explained about the need for concomitant medical therapy and phototherapy. And patient should be made aware that surgical treatment only provides a cosmetic camouflage to the skin but doesn't control disease activity. Patient examination. It should include detailed history taking as well as physical examination. Look for any new lesions, spread of existing lesions, or cauterization. Consent form describing the procedure and possible complications should be signed by the patient. Preoperative photography is important as it helps in comparison between the preoperative disease status as well as success after surgical procedure. It also helps in medico-legal situations. Preoperative investigations. It should include routine investigations like hemoglobin, complete blood count, bleeding time, clotting time, and random blood sugar. ECG may be needed in elderly. Coming to the surgical techniques in vitiligo, it can be classified as grafting techniques and non-grafting techniques. Grafting techniques may be tissue grafts or cellular grafts. Tissue grafts include mini punch graft, suction blister graft, thin split thickness graft, and others like hair follicle grafts, smash grafts, etc. Cellular grafts include non-cultured cell suspensions and cultured melanocytes or keratinocyte transplantation. Non-grafting techniques include micropigmentation, local excision of the lesion and primary closure, therapeutic wounding with dermabrasion, chemoabrasion, laser, etc. Coming to tissue grafts, first is miniature punch grafting or mini punch or mini grafting. It is the simplest and least expensive technique, but it has highest incidence of adverse effects. The principle of this procedure is that it involves the transfer of punches of skin tissue from the donor area into similar shaped pits made on the recipient skin. It requires, the image shows the instruments required for mini punch graft. It requires an insulin syringe for local anesthesia, then punches of size 1 to 1.5 mm, then graft holding or jeweler's forceps, scissors, then dressing. Then procedure. The recipient area is prepared and infiltrated with 2% lignocaine. Then 1 to 1.5 mm diameter punches are made at reticular dermis depth. The punches are taken first along the outer border. This is to avoid perigraph halo, and then throughout the recipient area, and these should be located 5 to 10 mm from one another. Then the donor site is usually gluteal area, thigh, upper arm or retroauricular area. Similar size punch grafts are taken from the donor area, which should be up to the depth of upper dermis after infiltration with local anesthesia. So recipient area should be, recipient punches should be at reticular dermis depth, and donor punches should be at the depth of upper dermis. Then the grafts are placed at recipient chamber such that the upper surface of each graft lies at the level of the surrounding recipient skin. After the procedure, the recipient area is covered first with a non-adherent antibiotic-coated sterilized gauze followed by saline soap gauze pieces and a pressure dressing. The dressing is removed on 7th or 8th day followed by treatment of recipient area with puvasol, topical steroids or NB-UVB to hasten pigment spread from the donated grafts. So the first three images show the sequence of dressing. First is a paraffin embedded non-adherent dressing. Second is surgical gauze followed by bio-occlusive micropore. So these are some of the images of the results obtained after mini punch grafting. Complication. Donor site may have hypertrophic scarring and Koebner phenomena with development of fresh vitiligo lesions. Recipient site may have cobblestone appearance. This cobblestoning is due to while implanting the punch, if the level of the donor punch is above the level of the recipient skin, cobblestoning can occur. Then polka dot appearance, depigmentation of the grafts and perigraft halo. Then other complications include graft rejection, hypertrophic scar or keloid, variegated appearance with color mismatch. The advantages of this procedure is that it is the easiest, fastest, least aggressive and least expensive method and helpful to treat difficult areas like fingertips, toes, areola, palms and soles. It is also useful for lesions with geographic borders and perigraft halo post split thickness graft. Disadvantages: it has a high incidence of adverse effects and the pigmentation produced by this technique is non-uniform, so it is not suitable for larger areas. Suction blister grafting. Here suction is used to obtain very thin grafts by causing a split at the dermo-epidermal junction, and these thin grafts are then applied onto the derma-abraded recipient skin. Principle: only the epidermal portion of donor area is grafted, which generally acquires the characteristics of the recipient site, leading to better color match and cosmesis. So it requires disposable syringes of 10 cc or 20 cc size, 50 cc syringe, then a 3-way cannula, dermabrader, and others like scissors and forceps. Procedure: the donor area is prepared first by shaving and then a surgical cleaning with 10% povidone iodine and spirit, and it is infiltrated with silocaine as a field block, or topical anesthesia can also be applied. Then blisters are raised using syringes. Alternatively, suction pump or suction cups or a negative pressure cutaneous suction chamber may be used. The induction time of blisters are usually 2 to 3 hours. So here a 20 cc syringe, the piston of a 20 cc syringe is removed and it is fixed to the skin and is connected to a 50 cc syringe using a 3-way cannula. The 3-way cannula is unlocked and suction is applied through the 50 cc syringe by drawing its piston. To remove the extra air in the 50 cc syringe, the 3-way cannula is locked and the air is removed. And for further suction, the 3-way cannula is again unlocked and the piston of the 50 cc syringe is withdrawn. This is continued till sufficient suction is acquired to produce a blister. Multiple such 20 cc syringes can be used to produce multiple blisters at a time. So when the blisters are formed, the 3-way cannula is unlocked and the syringe is removed. So the image shows multiple small blisters being formed which coalesce to form large blister. If the size of the blister, the graft should be more than the size of the recipient area. So if the size of the blister formed is not adequate, either we can increase the suction, negative pressure or we can inject intradermally saline into the blister so that the size increases. Once adequate size blister is formed, as shown in the image, the roof of the blister can be removed by cutting with an iris scissors, and the graft is then transferred onto a glass slide with dermal side facing upwards. The graft is then spread to its maximum size. Then using a 15 mm needle, multiple pinpoint openings are created on the graft. This is to ensure that after graft, if at all any serous fluid is collected beneath the graft, this can be drained easily, and this prevents seroma formation and graft rejection. So the donor site is then cleaned and bandaged using non-adherent dressing such as chlorhexidine gauze, like Bactigras. The recipient area is surgically cleaned and anesthetized, and then dermabrated using a manual or motorized dermabrader till minute pinpoint bleedings are visible. Then the blister grafts are placed with dermal side of graft in contact with the dermabrated area. The graft is pressed firmly. This ensures there is no serum fluid connection beneath the graft, as well as it helps in adhesion of the graft to the recipient area. Alternatively, surgical glue can be used for adhesion. Then after the procedure, non-adherent dressing followed by dynaplasty is applied. Dressing removed after 8 days. The graft falls off in 1 to 2 weeks. So it is essentially a method of melanocyte transplant. Patient may be started on NB-UVB, PUVA or Puvasol after 2 weeks. Maximal pigmentation usually occurs after the first 3 to 4 months. Complications. The donor site may have pain during blister formation and harvesting and Koebner phenomena. Recipient site may develop hyperpigmentation and incomplete pigmentation, perigraft halo, infection, hematoma and ecchymosis, wrinkling and displacement of the graft rejection. The advantage of this procedure is that it is simple, safe and inexpensive and provides excellent cosmetic matching with minimal scarring. It is most suitable for small localized patches of vitiligo, facial vitiligo, lips and areolae. The disadvantage is that it is time consuming, not suitable for palms and soles and covers limited area in a single session. So these are the results of some of the suction blister grafting. Coming to thin split thickness grafting, the principle is it involves the transfer of epidermis and uppermost part of superficial dermis, detaching it from its blood supply, thereby transferring melanocytes and keratinocytes from the donor site to the dermabrated vitelliginous site. The biological changes observed following skin grafting include graft uptake and adherence, graft revascularization and contraction. The instruments required are dermabraders, skin grafting equipments like Humpy's skin grafting knife or straight artery forceps with a razor blade or Silver's razor blade holding knife for harvesting the graft. And surgical glue, others like iris scissors, sterile petri dishes. So the donor area is first prepared, surgically cleaned and then infiltrated with local anesthesia. Either eutectic mixture of lidocaine and prilocaine can be given, or if local infiltration anesthesia is given, then a field block around the lesion is preferred. The block should not be infiltrated throughout the lesion, as these can cause bumps which may produce an uneven surface which interferes with the harvesting of the graft. So the skin is fresh and the graft is taken. An ideal split thickness graft should produce pinpoint bleeding as shown in the image after the harvesting. The harvested graft is then transferred onto a glass slide with dermal side facing upwards. It is spread properly. The size of the graft should be more than the recipient area. The recipient area is then surgically cleaned and dermabraded after infiltration with anesthesia, and the graft is then transferred onto the recipient area with dermal side towards the dermabraded surface. Then surgical glue is applied for proper adherence of the graft. So this shows the dressing in the sequence of dressing. First non-adherence dressing, then followed by surgical gauze and then pressure dressing. In post procedure, there should be strict immobilization. Antibiotics and anti-inflammatory drugs are given for 1 week. The first dressing can be changed after 24 hours to check for any seroma or hematoma formation. Final dressing removed after a week carefully by using saline to moisten it to prevent the graft dislodgement. Donor site dressing can also be changed after 1 week. Complete repigmentation is achieved in 2 to 3 months. Complication. Donor site complication includes scarring, PIH and Koebnerization. Recipient site may have milia formation, graft rejection with seroma or hematoma formation, stuck on tire patch appearance as shown in the image, hyperpigmentation, perigraft halo, scarring, secondary infection, hypertrophic scarring or recurrence. The advantage of this procedure is that it has the highest success rate with simple and cost-effective technique. Large areas can be dealt with in a single session. Excellent cosmesis with uniform pigmentation, partial to near total repigmentation of leukotrichia, and it is helpful for lesions in eyelids, inner cathesophytes, nipple, areola and genitals. Disadvantages. When large areas are to be treated, there is a limitation of donor site and it requires surgical skill for harvesting. Thicker graft can cause scarring of the recipient and donor areas, and difficult to treat areas using this procedure involves tips, soles, palms, body folds, and mucous membrane. There is a risk of malignant transformation when keratinized grafts are applied on oral mucosa. Some miscellaneous grafting, ultra-thin skin grafting. It is a variant of split-thickness skin graft where the graft harvested is translucent, measuring less than 0.15 mm in size with minimal or no dermal tissues under the surface. Then mesh grafting. Here the harvested graft is expanded by meshing it either manually or by using a meshing apparatus. This increases the size of the graft by 4 to 6 times its original size. Then seed grafts or smash grafts, which is also called as poor man's cell culture. So cell culture techniques, cell grafting techniques are actually costly procedure. So this can be an alternative and it is comparatively cheap. So it is a variant of ultra thin and split thickness skin graft where the sheets of tissues are minced to fragments less than 1 mm in size with the help of sterile scissors. This paste is then applied to the prepared recipient site. The smaller the particles, better will be the result. A modification to this procedure is to insert the minced graft with the help of needling into the dermis. Flip-top grafting. In this, a hinge of tissue is raised in the epidermis at the recipient site and small pieces 1 to 2 mm of size of donor tissue are slid underneath this with the dermal side down. This provides cheap, natural and effective dressing. It also allows us to see the extent of repigmentation and determine the success of the procedure. Hair follicle grafting. This is very similar to the follicular unit extraction or strip follicular transplant techniques of hair transplant. The follicular unit or strips are then transplanted onto the recipient area. Donor site is usually hair on the occipital area of the scalp, and spacing between the transplanted hair is usually 5 to 10 mm. The principle of this procedure is that the outer root sheath of the hair follicle has a reservoir of inactive melanocytes which expresses different antigens than those found on the active epidermal melanocytes, which are destroyed in vitiligo. So they are more resistant to vitiligo depigmentation. These inactive melanocytes, when stimulated, migrate to the epidermis and becomes active and causes repigmentation. Coming to cellular grafts. It includes non-cultured epidermal cell suspension, non-cultured hair follicle outer root sheath cell suspension, and cultured melanocyte or keratinocyte transplantation. The advantage of this procedure is that large vitiliginous lesions can be treated using small donor tissue. But it really requires expertise, costly equipments and supplies, good manufacturing practices, and this limits its availability and utilization. Non-cultured epidermal cell suspension. The principle of this procedure is that split thickness or ultra thin sheets are mechanically and chemically separated into individual cells, and these are applied onto the recipient vitiliginous area, which is larger than the initial donor site. It involves 4 steps. First is harvesting the graft, similar to split thickness graft. Then preparation of the non-cultured epidermal cell suspension, which is the most important step. It involves trypsinization, where the harvested skin sample is transferred to a petri dish containing trypsin EDTA solution with epidermal side facing upward, which is then incubated for 45 minutes at 37 degrees Celsius. Then the excess trypsin is removed by adding 0.5% trypsin inhibitor. So this separates the epidermis and dermis. Following this, manual separation of dermis from epidermis can also be carried out using forceps. Then centrifugation. The solid tissue waste is removed and the obtained suspension is transferred to a test tube with DMEM media, and it is then centrifuged at 10,000 rpm for 5 minutes. The supernatant is discarded and pellet containing melanocytes and basal keratinocytes are resuspended in DMEM and used. So the image shows this procedure. So first, in the petri dish, the harvested graft is transferred first to the petri dish containing trypsin and EDTA. Then the second image shows the skin after reaction with trypsin. So skin is changed to a liquid form. The layers of skin are separated. The third image shows the separated skin layers. The white part is the dermis. The light brown part is the upper epidermal portion, and the dark brown portion is the melanocyte rich suspension. The the pellet is resuspended in DMEM and it is then transferred to the dermabrated recipient site using an insulin syringe along with simultaneous collagen dressing. Initial pigmentation may be noticed as early as 2 to 3 weeks. Maximal repigmentation takes 2 to 4 months and phototherapy can be initiated after 2 to 3 weeks. Then non-cultured extracted hair follicle outer root sheath cell suspension. The principle here is same as that of described in hair follicle transplantation. So hair follicles offer multiple subtypes of melanocytes and the stem cells express different surface antigens than those on epidermal melanocytes which are resistant to subsequent vitiligo depigmentation. So it has 4 steps. First is the follicular unit extraction from the donor area. For this 1 mm punch, manual or motorized are used to extract the intact hair follicles. The preferred donor site is occipital scalp. 15 to 25 is sufficient to repigment approximately 20 cm square area. Then cell separation, that is the preparation of cell suspension. The extracted follicles are washed and incubated in a test tube with trypsin EDTA solution at 37 degrees Celsius for 90 minutes to prepare single cell suspension. These test tubes are changed every 30 minutes for 3 cycles. And every time the tube is changed, the previous reaction happening on the previous test tube should be stopped by adding a trypsin inhibitor. So finally we get 3 test tubes of cell suspension. These cell suspension are combined and filtered using a 70 micrometer skin filter. It is then centrifuged for 5 minutes at 1000 rpm to obtain a cell pellet, which is again resuspended in small amount of DMEM or phosphate buffered saline. So the image shows this technique of punching out of hair follicles. Then it is transferred to media containing trypsin and EDTA. So the image D shows the keratin filament which is left behind after the procedure. The cell suspension is then centrifuged, producing a pellet which is shown in image E, which is then applied onto the dermabrated recipient skin. Coming to cultured autologous melanocyte transplantation, it is a very sophisticated procedure. The principle is replenishing melanocytes selectively within vitelligenous macules by autologous melanocyte transplantation. The advantage is that it allows treatment of larger recipient areas with smaller skin samples. The initial procedure is similar as before, that is harvesting of the skin graft and then incubation in trypsin EDTA solution. Here it is incubated at 4 degrees Celsius overnight, followed by preparation of the non-cultured suspension. Then this non-cultured suspension, the pellet is resuspended in 5 ml M2 melanocyte medium and it is then transferred to a culture flask containing M2 medium. This culture is then maintained at 37 degrees Celsius in a humidified 95% air and 5% carbon dioxide atmosphere for 2 to 3 weeks. The medium used is changed every 3 to 4 weeks. Then for harvesting the cells of transplantation, the culture medium is removed and trypsin EDTA solution is added. Then cells are pipetted out with neutralization of trypsin. Then the solution is centrifuged at 1000 rpm for 5 minutes and the pellet is resuspended in M2 medium, which is then transplanted onto the recipient site. So the image shows melanocyte culture on day 5 and 15. After the procedure, repigmentation starts appearing in 2 to 4 weeks and maximal repigmentation occurs in 4 to 6 months. Here there is a high donor-recipient ratio. Recipient areas as much as 100 times larger than the donor area can be treated with this procedure. Then it also allows cryopreservation whereby the sample can be used in future. Almost 70% cells are preserved after a period of 1 year. The newer development in this technique involves amniotic membrane and hyaluronic acid micropore sheets used as scaffolds for cultured melanocytes. That is, the cultured melanocytes are transferred into either of these, which is then directly transferred onto the dermabrated recipient area. Coming to non-grafting techniques, it involves micropigmentation or tattooing. This is just a cosmetic camouflage technique whereby deposition of exogenous inert pigment, mostly iron oxide, ferric oxide, into the superficial papillary dermis, similar to a tattoo. Then excision with primary closure. The entire depigmented area is removed, followed by primary closure. Then therapeutic wounding. This can be done using dermabrasion, laser, cryosurgery, needling, or by local application of phenol or trichloroacetic acid. This stimulates melanocytes from the periphery and the black hair follicles to proliferate, migrate, and repigment the lesion. Thank you.